Brand new, shocking research published in major cardiology journals reveals that one of the most commonly prescribed pills for seniors is quietly damaging hearts, increasing heart attack risk by up to 20%, doubling the risk of heart failure in some people, causing dangerous magnesium depletion that leads to arrhythmias and sudden cardiac death. And there's a very high chance you're taking this pill right now, or you know someone who is, because over 15 million Americans take this medication daily. 15 million. Most of them seniors. Most of them believing it's harmless. Just a simple pill for heartburn or acid reflux. Something you can buy over the counter without even seeing a doctor. But the research is absolutely clear and undeniable. This pill damages hearts, and you have absolutely no idea it's happening. What I'm about to share will make you furious. Because doctors prescribe this medication like candy. Take this for your heartburn. Take this to protect your stomach while you're on other medications. Take this indefinitely. Nobody explains the cardiovascular risks. Nobody mentions the studies showing increased heart attack rates. Nobody discusses safer alternatives. They just write the prescription or tell you to buy it over the counter. And millions of seniors take it every single day, year after year, while their hearts are being damaged silently. By the end of this video, you'll know exactly what this pill is, how it damages your heart, what the research shows, and most importantly, what safer alternatives exist, and how to work with your doctor to get off this medication if you're taking it. But I'm going to tell you right now, if you're taking this pill and nobody has warned you about the cardiovascular risks, you're not alone. Most people have never been told, and that's a massive failure of our healthcare system. Stay with me, because what you learn in this video could save your heart, could prevent a heart attack, could prevent heart failure, could save your life. This matters more than you realize. Before we begin, I want to tell you about our comprehensive blood pressure control ebook. It includes detailed information about medications that affect cardiovascular health, including the pill I'm about to discuss. Complete strategies for protecting your heart. How to work with your doctor on medication management. Everything organized in one actionable system. The link is in the description. If you're concerned about your heart health and want complete protocols, check the description after this video. Now let me tell you about Robert, and I need you to pay very close attention because I promise you're going to recognize yourself or someone you love in this story. Robert was 71 years old. 10 years ago, he started experiencing heartburn, burning sensation in his chest after meals, especially after eating anything acidic or spicy. His doctor said it was gastroesophageal reflux disease, GERD. Very common, nothing to worry about, and prescribed a medication. Take this once daily, his doctor said. It will stop the acid production and you'll feel better. Robert started taking the pill. Within days, his heartburn was gone, completely gone. He could eat anything without that burning sensation. It was miraculous. He took the pill faithfully every single morning. One pill, no heartburn. Simple. His doctor said to stay on it indefinitely. GERD is a chronic condition. You'll need to take this long-term to keep the acid under control. Robert didn't question it. The pill worked. He felt better. Why would he stop? 10 years. Robert took this pill every single morning for 10 years. Never missed a dose. Never questioned whether he still needed it. His doctor never suggested stopping. Never mentioned that it was only supposed to be used short-term. Never discussed the risks of long-term use. Just kept renewing the prescription year after year. Then, 2 years ago, Robert started experiencing symptoms. Fatigue that was overwhelming. He'd feel exhausted just walking from his car to the grocery store. He'd have to sit down and rest. His heart would be pounding. He'd feel short of breath. Something was wrong. He went to his doctor. His doctor ordered tests. An echocardiogram showed that Robert's heart function had declined. His ejection fraction, the measure of how well his heart pumps blood, was 45%. Normal is 55 to 70%. Robert was developing heart failure. His heart wasn't pumping efficiently anymore. Blood was backing up in his lungs, causing shortness of breath. Fluid was accumulating in his legs, causing swelling. Robert was shocked. How did this happen? I don't have heart disease. My cholesterol is fine. My blood pressure is controlled. Why is my heart failing? His doctor didn't have a clear answer. Sometimes heart failure develops without obvious cause. We'll start you on medications, diuretics for the fluid, an ACE inhibitor to help your heart pump better, beta blocker to slow your heart rate. Robert started the heart failure medications. His symptoms improved slightly, but he still felt exhausted, still short of breath with minimal exertion, still had swelling in his ankles. His life had changed dramatically overnight, and he didn't understand how it had happened. Robert couldn't walk more than 50 feet without having to stop and catch his breath. He'd walk from his car to the entrance of the grocery store and have to lean against the wall, breathing hard, heart pounding, feeling like he'd just run a marathon. Other shoppers would pass him looking concerned. "Are you okay, sir?" He'd wave them off, embarrassed. "I'm fine, just resting." But he wasn't fine. His heart was failing. Every step required enormous effort because his heart couldn't pump enough blood to his muscles. His legs would feel heavy, weak, like they were filled with concrete. He'd have to sit down in the store. Sometimes he'd give up entirely and go home without getting what he came for. Robert stopped going places, stopped visiting friends, stopped doing errands. Everything required too much physical effort. Everything left him exhausted and gasping for air. His world shrank to his house, his chair, his bed. The life he'd known was gone. The shortness of breath was terrifying. Robert would be sitting on the couch and suddenly feel like he couldn't get enough air. He'd take deep breaths but still feel starved for oxygen. His chest would feel tight, heavy, like something was sitting on it. He'd panic. Am I having a heart attack? Am I dying? The panic would make the breathing worse. He'd have to focus on slowing his breathing, calming down, reminding himself it was the heart failure, not a heart attack. But the fear never went away. At night, it was worse. Robert couldn't lie flat anymore. When he'd lie down, fluid that had accumulated in his lungs during the day would shift and make breathing even more difficult. He'd feel like he was suffocating, drowning. He had to sleep propped up on 3 pillows, sometimes 4, sitting almost upright. His neck would hurt from the awkward angle. His back would ache. But it was the only way he could breathe comfortably enough to sleep. Some nights, he couldn't sleep at all. He'd sit on the edge of the bed at 2 a.m., struggling to breathe, terrified, wondering if this was it. If this was the night his heart would give out completely. He'd consider calling 911. But what would they do? Tell him it was his heart failure? Give him more medications? Send him home? He'd sit there for hours, breathing slowly, praying for morning. Robert's ankles swelled every day. By evening, they'd be puffy and swollen. His shoes wouldn't fit. He'd have to take them off and walk around in socks. When he'd press his finger into the swollen tissue, it would leave an indentation that stayed for 30 seconds. Pitting edema, his doctor called it. Fluid backing up because his heart couldn't pump it effectively. The swelling was humiliating. Robert would be sitting at a family gathering and someone would notice his swollen ankles. "Uncle Robert, are your ankles okay? They look really swollen." He'd pull his pant legs down to hide them. "It's fine, just the heart failure." Just the heart failure. As if it were nothing. As if his heart slowly failing was just a minor inconvenience. Robert was exhausted all the time. Not just from the physical effort of moving around, but bone-deep fatigue that never went away, no matter how much he rested. He'd wake up tired, spend the day tired, go to bed tired, sleep poorly because he couldn't lie flat, wake up tired again. The cycle never ended. He'd fall asleep in his chair at 2 p.m. His wife would find him there, mouth open, breathing heavily. She'd wake him for dinner. He'd eat without appetite and go back to sleep by 7 p.m. He felt like all he did was sleep, and still he was exhausted. His body was starved for oxygen because his heart couldn't deliver it. Every cell in his body was struggling. Robert became depressed. Not just sad, clinically depressed. His life had been taken from him. He couldn't do anything he used to enjoy. Couldn't garden, couldn't golf, couldn't even walk around his own neighborhood without becoming short of breath. He felt useless, broken, like a burden to his wife, who now had to do everything he couldn't do anymore. He'd think about his father. His father had died from heart failure at 76. Robert remembered visiting him in the hospital those last weeks, seeing his father struggle to breathe, seeing the fear in his eyes, the oxygen mask, the IV medications, the steady decline until finally his heart stopped. Robert was 71. Was that his future? 5 more years of this suffering, and then death? Robert was terrified of dying. Every night when he couldn't breathe properly, he'd think, "This is it. This is how I die, suffocating slowly as my heart fails." He'd never been afraid of death before, but now it was all he thought about. How much time did he have? Would he die suddenly? Or slowly over years, getting progressively weaker and more disabled until finally his heart gave out? His doctor had explained that heart failure was progressive. It doesn't get better, only worse. They could manage it with medications, slow the progression. But ultimately, his heart would continue to fail. Eventually, the medications would stop working. Eventually, he'd need more intensive treatment. Maybe a heart transplant, though at 71 he probably wasn't a candidate. Maybe just palliative care, comfort measures until the end. Robert felt like he'd been handed a death sentence. And he didn't understand how it had happened. He didn't have heart disease. His cholesterol was fine. His blood pressure was controlled. He'd never had a heart attack. How did his heart just start failing? Nobody could explain it. Just, sometimes this happens. Just bad luck. Just aging. Then Robert came to see me for a second opinion. I reviewed his medical history carefully. I looked at all his medications, and one jumped out immediately: the heartburn pill he'd been taking for 10 years. I asked Robert, "Do you still have heartburn? Do you still need this medication?" Robert thought about it. "Actually, I haven't had heartburn in years. I don't even remember the last time I felt it. But my doctor said I need to stay on it." I explained to Robert that the pill he was taking, the pill he'd been on for 10 years, had been linked in multiple studies to increased risk of heart failure. That long-term use was associated with magnesium depletion, which affects heart rhythm and function. That the very medication he thought was harmless might have contributed to his heart failure. Robert stared at me in disbelief. My heartburn pill caused heart failure? I couldn't say definitively that it caused his heart failure, but it was certainly a significant risk factor that nobody had warned him about. And it was a medication he probably didn't even need anymore, since he hadn't had heartburn in years. But I'm not going to tell you what pill Robert was taking yet. Because first, you need to understand why this pill damages hearts. You need to understand the mechanisms. Because without understanding how it works, you'll dismiss this as correlation without causation. You'll think the studies are exaggerating, and you'll keep taking the medication while your heart is being damaged. Comment below right now if you take a pill for heartburn or acid reflux. Type heartburn pill so I can see how many of you are on these medications. Because I'd bet a significant portion of you watching take one of these pills daily, and most of you have no idea about the cardiovascular risks. Now let me explain what happens in your body when you have heartburn or GERD. Your stomach produces acid to digest food. Normally, a valve at the top of your stomach, called the lower esophageal sphincter, keeps that acid in your stomach where it belongs. But sometimes that valve doesn't work properly. Acid escapes up into your esophagus. Your esophagus isn't designed to handle acid. It burns. That's the burning sensation you feel in your chest. That's heartburn. The pill that's damaging hearts works by shutting down acid production in your stomach. These pills are called Proton Pump Inhibitors, or PPIs. They block the enzyme in your stomach lining that produces acid. No enzyme activity means no acid production. No acid means no heartburn. Problem solved. Common PPIs include omeprazole, Prilosec, esomeprazole, Nexium, lansoprazole, Prevacid, pantoprazole, Protonix, and rabeprazole, Asifex. These are some of the most prescribed medications in the world. Millions of people take them daily. Many are available over the counter without prescription. PPIs are incredibly effective at stopping heartburn. They work better than any other class of medication for acid-related problems. That's why they're prescribed so often. That's why people love them. One pill and the heartburn is gone. But here's what most people don't know. PPIs were only approved for short-term use. 4 to 8 weeks for healing stomach ulcers or severe esophagitis. Maybe up to 6 months for specific conditions. They were never intended for the 10 years Robert took them. They were never meant to be taken indefinitely by millions of people. Yet that's exactly what happens. Doctors prescribe them long-term. People buy them over the counter and take them for years. Nobody questions it. Nobody stops to ask, is this still necessary? What are the long-term risks? And the long-term risks to the heart are significant and well documented. Let me explain the mechanisms. First, PPIs cause magnesium depletion. Magnesium is absorbed in your intestines. The absorption process requires stomach acid. When you suppress acid production with PPIs, magnesium absorption is impaired. Over months and years of PPI use, magnesium levels gradually decline. The deficiency develops slowly. You don't feel it happening, but it's happening. Magnesium is critical for heart function. It's required for normal heart rhythm. It helps regulate calcium movement in and out of heart muscle cells. When magnesium is deficient, heart rhythm becomes unstable. Dangerous arrhythmias can develop: atrial fibrillation, ventricular tachycardia, even sudden cardiac arrest. Studies have shown that PPI users have significantly higher rates of these arrhythmias compared to non-users. Second, PPIs impair endothelial function. The endothelium is the thin layer of cells lining your blood vessels. It produces nitric oxide, which keeps vessels dilated and flexible. PPIs interfere with an enzyme called DDAH that breaks down a compound called ADMA. When DDAH is inhibited, ADMA accumulates. High ADMA impairs nitric oxide production. Less nitric oxide means stiffer blood vessels, increased blood pressure, increased risk of blood clots, increased risk of heart attack. Research published in the journal Circulation showed that PPI users had measurable impairment of endothelial function within just weeks of starting the medication. Blood vessels became less responsive. Blood flow was compromised. The cardiovascular system was being damaged. Third, multiple large studies have found associations between PPI use and increased cardiovascular events. A study published in PLOS One analyzed data from over 2.9 million people and found that PPI users had a 16 to 21% increased risk of myocardial infarction compared to people using H2 blockers. The risk was present even in people without existing heart disease, even in people taking PPIs for what seemed like a benign reason, like mild heartburn. Another study published in Circulation, Cardiovascular Quality and Outcomes, followed nearly 3 million people and found that PPI users had approximately double the risk of developing heart failure compared to non-users. The risk increased with duration of use. People on PPIs for more than 5 years had even higher risk than those on them for less time. Robert had been on his PPI for 10 years. A study in the Journal of the American Medical Association, JAMA, Neurology, found that PPI use was associated with increased risk of dementia. Another in JAMA Internal Medicine found increased risk of chronic kidney disease. And yet another in BMJ Open found increased risk of osteoporosis and bone fractures. These pills that millions take daily, that are sold over the counter, that people think are completely safe, have serious long-term risks affecting multiple organ systems, including the heart. The FDA has issued warnings about magnesium depletion with long-term PPI use. They recommend checking magnesium levels in people on PPIs long-term, especially if they're also taking other medications that can lower magnesium. But most doctors don't routinely check. Most patients have no idea this is a concern. Robert's magnesium had never been checked in 10 years of PPI use. Now, before I tell you what safer alternatives exist and how to get off PPIs safely, please hit the like button. Your like helps this video reach more people taking PPIs who have no idea about these risks. More seniors whose doctors never warned them. Please hit like right now. So what are the alternatives? First, H2 blockers. These are a different class of acid-reducing medications. Famotidine, Pepcid, cimetidine, Tagamet, nizatidine, Axid. Ranitidine, Zantac, was recalled due to contamination issues, but the other H2 blockers remain available. H2 blockers reduce acid production, but through a different mechanism than PPIs. They block histamine receptors in the stomach lining instead of blocking the proton pump directly. H2 blockers don't have the same cardiovascular risks as PPIs. They don't impair magnesium absorption. They don't affect endothelial function the same way. The large studies showing increased heart attack and heart failure risk with PPIs found no such association with H2 blockers. In fact, H2 blocker users in those studies had cardiovascular outcomes similar to people using no acid-suppressing medications at all. H2 blockers aren't as powerful as PPIs. They don't suppress acid as completely, but for many people, they're effective enough. They reduce acid production by about 70% compared to PPIs, which reduce it by 90 to 95%. That 70% reduction is sufficient to control symptoms for most people with mild to moderate GERD. Second, lifestyle modifications. These should be first-line treatment, not medications. Elevate the head of your bed 6 to 8 inches by putting blocks under the bed frame. This uses gravity to keep acid in your stomach instead of allowing it to flow up into your esophagus. Don't eat within 3 hours of bedtime. Give your stomach time to empty before lying down. Avoid trigger foods, caffeine, alcohol, chocolate, spicy foods, acidic foods like tomatoes and citrus, fatty foods. Different foods trigger different people. Keep a food diary to identify your triggers. Lose weight if overweight. Excess weight increases pressure on your stomach, pushing acid up. Stop smoking. Smoking weakens the lower esophageal sphincter. Third, natural approaches. Deglycyrrhizinated licorice, DGL, taken 15 minutes before meals, can coat and soothe the esophagus. Slippery elm lozenges or tea have similar soothing effects. Aloe vera juice can reduce inflammation in the esophagus. Ginger can help with digestion and reduce reflux for some people. These aren't as powerful as medications, but they have zero side effects and work for many people with mild symptoms. But here's the critical issue that traps people on PPIs. You cannot just stop them abruptly. When you've been on PPIs long-term, your stomach has adapted. The cells that produce acid, called parietal cells, have multiplied. They've increased in number trying to compensate for the suppression. Your stomach is trying to overcome the medication. If you suddenly stop the PPI, all those extra parietal cells start producing acid at once. You get massive rebound hyperacidity. Acid production shoots up higher than it was even before you started the PPI. The heartburn comes back with a vengeance. Severe burning. Worse than you ever had before starting the medication. This rebound effect traps people. They try to stop. The rebound heartburn is unbearable. They think, I can't function without this pill. I need it. They start taking the PPI again. And they're trapped for years. The rebound is real. It's well documented. Studies show it happens in up to 40 to 50% of people who stop PPIs abruptly. Even people who never had heartburn before can develop rebound acid hypersecretion after stopping PPIs. The medication itself creates the dependency. The safe way to stop PPIs is to taper gradually. Here's the protocol that works. Week 1-2. If you're taking a PPI twice daily, reduce to once daily. If you're taking once daily at full dose, like omeprazole 40 milligrams, reduce to half dose, 20 milligrams. Start an H2 blocker like famotidine 20 milligrams twice daily. Implement lifestyle changes aggressively. Elevate bed. No eating 3 hours before bed. Avoid all trigger foods. Week 3-4. If you reduced from twice daily to once daily, now reduce to once daily at half the dose. If you were already on once daily, reduce to every other day. Continue the H2 blocker. Some rebound heartburn may occur. Use DGL and antacids as needed for breakthrough symptoms. Don't give up. The rebound will pass. Week 5-6. Reduce PPI to every other day if you're still on daily, or every third day if you're already on every other day. The goal is gradual reduction. Continue H2 blocker. The rebound symptoms should be lessening as your stomach adjusts. If symptoms are unbearable, slow the taper. Stay at each reduction step for 2 weeks instead of 1 week. Week 7-8. Stop the PPI completely. Rely on the H2 blocker and lifestyle modifications. There will likely be some rebound heartburn even with the taper, but it should be manageable. Use antacids for breakthrough. Use DGL before meals. The rebound typically peaks around week 2 after stopping completely, then gradually improves over the next 2 to 4 weeks. Week 9-12. Continue H2 blocker as needed. Many people can reduce or stop the H2 blocker after a few weeks once the rebound has completely resolved. Some people need to stay on a low-dose H2 blocker long-term. That's okay. H2 blockers are much safer for long-term use than PPIs. This tapering protocol takes 8 to 12 weeks. That seems long, but after years on a PPI, taking 3 months to safely discontinue is reasonable. Rushing it increases the chances of severe rebound that forces you back onto the PPI. Slow and steady wins. Robert and I worked with his gastroenterologist to safely discontinue his PPI using this exact protocol. We tapered over 8 weeks while implementing lifestyle changes and using famotidine as needed. The first 2 weeks were rough, some rebound heartburn, but it was manageable. By week 4, the rebound had subsided. By week 8, he was completely off the PPI with minimal heartburn managed by lifestyle alone. We also corrected his magnesium deficiency with supplementation. His magnesium level had been 1.6 milligrams per deciliter, which is low. Normal is 1.7 to 2.2. We supplemented with 400 milligrams of magnesium glycinate daily. Within 3 months, his level was 2.0, normal. And remarkably, Robert's heart function improved. His ejection fraction increased from 45 to 52% after 6 months off the PPI. Still not perfect, but significantly better. His symptoms improved dramatically. He had more energy. He could walk further without getting short of breath. He could sleep with just 1 pillow instead of 3. The ankle swelling decreased. The overwhelming fatigue lessened. Getting off the PPI and correcting the magnesium deficiency allowed his heart to recover to some degree. The damage wasn't entirely reversible. Once you develop heart failure, the heart is never quite the same. But stopping the medication that was contributing to the damage allowed what recovery was possible. Robert said something during one of our follow-up visits that I'll never forget. I took that pill every morning for 10 years, thinking it was helping me, thinking it was harmless, and the entire time it was damaging my heart. Nobody warned me. Nobody checked my magnesium. Nobody suggested stopping it even though I hadn't had heartburn in years. If I'd known 5 years ago, maybe my heart wouldn't have failed. Maybe I could have prevented this. His story haunts me because there are millions of people in his exact situation, taking PPIs daily, for years, believing they're harmless, never warned about cardiovascular risks, never having their magnesium checked, never reassessing whether they still need the medication, and their hearts are being damaged silently. Now let me give you the action plan. First, if you're taking a PPI, ask yourself honestly, do I still need this medication? When was the last time I had heartburn? Have I been taking this for years simply because I never stopped? Many people continue PPIs indefinitely just because nobody suggested stopping. The prescription gets renewed automatically. They take it out of habit, not necessity. Second, talk to your doctor about the cardiovascular risks of long-term PPI use. Don't accuse or blame, just express concern. I've read that long-term PPI use is associated with increased heart attack and heart failure risk. I've been on this for X years. Can we discuss whether I still need it or if there are safer alternatives? Most doctors will work with you if you approach it collaboratively. Third, if you do need acid suppression because you have active symptoms, try to use the lowest effective dose for the shortest time necessary. PPIs are incredibly effective for healing ulcers and severe esophagitis. Use them for that specific healing period. Then taper off and maintain with lifestyle changes and H2 blockers if needed. Don't take PPIs indefinitely without regular reassessment. Every 6 months, ask, do I still need this? Fourth, implement lifestyle modifications as first-line treatment before starting PPIs. Most mild to moderate GERD can be controlled with bed elevation, dietary changes, weight loss, and not eating before bed. These work, have 0 side effects, and address root causes. Medications should be second line, not first line. Fifth, if you've been on PPIs long-term, ask your doctor to check your magnesium level. Request RBC magnesium, red blood cell magnesium, not serum magnesium. Serum magnesium only measures what's in your bloodstream, which is a tiny fraction of total body magnesium. RBC magnesium measures what's in your cells, which is far more accurate for detecting deficiency. Normal range is typically 4.0 to 6.5 milligrams per deciliter. Optimal is above 5.0. If you're deficient, Supplement with 300 to 400 milligrams of magnesium glycinate daily. Recheck in 3 months. Sixth, if you decide to taper off PPIs, commit to the full 8 to 12-week protocol. Don't rush it. The rebound will happen whether you stop abruptly or taper, but tapering makes it manageable instead of unbearable. Have antacids, DGL, and H2 blockers ready for breakthrough symptoms. Know that the rebound will pass. It's temporary. Your stomach will readjust. You can get off these medications successfully if you're patient and methodical. Now, the critical disclaimer. Everything I've shared is for educational purposes only and should not replace medical care. Never stop PPIs abruptly, especially if you're taking them for serious conditions like Barrett's esophagus, severe esophagitis, or active ulcers. Always work with your doctor on any medication changes. The rebound hyperacidity from stopping PPIs abruptly can be severe and potentially dangerous. Some people truly need PPIs for specific medical conditions and should not discontinue them. The goal isn't to eliminate PPIs entirely from medicine. PPIs are valuable medications when used appropriately. The goal is to use them wisely, at the lowest dose, for the shortest time necessary, for appropriate indications, with awareness of risks and benefits, and with regular reassessment of continued need. Tonight, think about Robert. 10 years on a PPI for heartburn he no longer had. Developed heart failure that stole his ability to breathe, to walk, to live normally. Nobody connected it to his heartburn pill until it was nearly too late. Then we safely discontinued the medication, corrected his magnesium deficiency, and his heart recovered to some degree. His symptoms improved. His life improved. You might be taking a PPI right now for heartburn you no longer have. You might have been on it for years without reassessment. You might be damaging your heart while thinking you're just taking a harmless pill for acid reflux. The only way to know is to ask, to reassess, to work with your doctor on whether you still need this medication or if safer alternatives exist. Your heart matters infinitely more than the convenience of a pill. If lifestyle changes and H2 blockers can control your symptoms without the cardiovascular risks of PPIs, isn't that worth the effort? If tapering off over 12 weeks means you get off a medication that's increasing your risk of heart attack and heart failure, isn't that 12 weeks well spent? Robert would tell you, it's worth it. Getting off the PPI was challenging. The rebound heartburn was uncomfortable for a few weeks. But getting his life back, having his heart function improve, being able to breathe and walk and sleep comfortably again, that was worth every moment of discomfort during the taper. Share this video with everyone you know taking PPIs, your parents, your friends, your neighbors. Millions of seniors take these pills daily with no awareness of the cardiovascular risks. Your share could save someone from heart failure, could save someone's life. Please share. Check out our blood pressure control ebook for complete protocols on protecting your cardiovascular health, including detailed information about medications and their effects. Link in the description. And most importantly, take action. If you're on a PPI, talk to your doctor tomorrow. Ask about alternatives. Ask about tapering. Ask about your magnesium level. Advocate for your heart. You deserve to know the risks of medications you're taking. You deserve the opportunity to use safer alternatives when they exist. Take care of yourself. Reassess your medications. Protect your heart. And I'll see you in the next video where we continue giving you information that can genuinely save your health and your life.